Positional release techniques. I love this quote from Leon Chaito, who's a renowned osteopath who wrote many books on positional release. And he describes it as a way of inviting change rather than demanding it. And that's exactly what we're going to be doing here. We are not doing unto the client. We're simply helping to position that tissue where they feel tenderness or spasm, and then just holding, allowing their body to change. So I think bear that in mind when it comes to this technique. So what is it? It's a spontaneous release by positioning. Simple as that. It's probably one of the most basic techniques, but yet one of the most powerful that you will learn to use. It's a neuromuscular technique, so we're working with the nervous system and helping to create a response in the tissue by positioning the body in a certain way. There are many types of positional release. Strain, counter-strain, or SCS, which is the one that we're going to teach you and show you today. There's also functional technique, balanced ligamentous tension, visceral technique, the Mackenzie technique, and there are even taping techniques out there where they will tape very local areas of tissue into a position of ease that can be held for longer durations. So they all come from this basic concept that we take where there's tenderness or spasm. We then shorten that muscle more, putting it into a position of ease, hold it, and then when we return to neutral, there has been a release in that tissue. So they're all different ways of creating that based on that same principle. So SCS, strain counter strain, was discovered by Lawrence Jones. So Dr. Jones actually found this by accident. He was working with a client back in the 60s who had neck pain and couldn't sleep. So the focus of the session with Jones was to find a position of ease to allow the client to sleep in. They worked in different positions and then found a position where the client felt no pain in their neck, and Jones left him there for a short period of time. What he found was that when he resumed back to his normal position, the pain was gone. So really, although it was an accidental discovery, when he thought that through, he realized what he had done was simply put the client's neck, where they had felt the pain, into a shortened position, and it was held there while the client was relaxed. So that's another key to this. And then the pain was gone. So from the Upledger Institute, they've described it as often in order to open a latch, we must first exaggerate the closing. So if we think about a muscle being in a short, tight spasm position, if we shorten that more, so exaggerate that shortening, and we hold it, then it might just open up. So there are lots of benefits of strain counter strain, and there's plenty of research out there. There's definitely more specific research that could be done, but there's a lot of research which shows that it can help reduce pain, especially in the neck, upper traps and jaw. It's also been shown to help improve function. So for example, performance of the ankle when it comes to things like balance. It can be used to increase range of motion by reducing that tone in the tissues. So for example, there's research on hip flexors and again, jaws and necks. It's also been shown to improve strength. Hip, arm and wrist have all been shown to improve strength post a course of strain counter strain. So there's lots of evidence that suggests that it may well be a change in some of those measurable outcomes across pain, function, range of motion and strength. But like many manual therapies, the why it works is not yet definitive. And I think until we understand what's happening, it's very hard to make claims as to what a lot of these manual therapies can do. But what we can certainly do is try these in practice, see a response, and as always, if it's a tool that works for your client, integrate it into their treatment plans. So why does it work? As we said, we don't know for sure. There's a thought process out there that it's to do with muscle excitability and the stretch reflex. working and stimulating the muscle spindles and connective tissue to create a change in resting tone? Are we simply breaking that spasm pain cycle that a client is in by positioning them into ease? So we're breaking that cycle and getting a long-term effect. Or are we simply creating safety? Are we taking tissue that feels threatened, unsafe, putting it in a position of safety and allowing the brain to connect those neural tags which says that stimulation in that tissue actually doesn't create pain. And then when we return to neutral, we are without that pain response. We don't know. I think what you need to do is think through what you think might be happening so that you can explain this to your client, and if they're bought into the process, then you're halfway there. So getting them to trust you, to allow you to work with them and try these or any manual therapy is a big step forward in getting those results. Once we've identified our target tissue, in the case of this short video, the suboccipitals, we're going to palpate the most tender point within that tissue. Now, wherever that is on the pain scale, we're going to tell our client that this is our 10, and we're going to compare every position we're in after this point to that 10. The next step is to move the tissue into a shorter position of ease. And we're going to do one movement at a time. So here you've seen me just move into lateral side flexion. And I've asked my client to say, has that made it easier or has it made it worse? If it's brought it into a position of ease, I'm now asking them to give it a number between 1 and 10. For example, my client here has said he's now at a 7 out of 10. The key to this technique is we want to get a reduction of about 70%. So we want to get that tenderness down to about a 3, maybe even a 2 before we hold that pattern. So we fine tune. So once we've established a 7 on side bending, I'm going to add a little bit of rotation perhaps. And again, communication is key. I'm asking my client, where are we now against that 10? And here he's saying we're at a 3. But for example, if we were still at a 4, a 5, I might bring his head into a little bit of extension, for example. If that makes it worse, bring the head into a little bit of flexion. It's about fine-tuning communication and playing with that position until that tender point becomes a 3. Once we've found that spot, we simply hold it for 90 seconds, in which time just coach your client to stay relaxed. Keep them breathing nice and deep, nice and slow. And once that 90 seconds is up, we do a slow return to neutral. And that's really important. If we move too fast here, too rapid, we don't want to trigger a response of those muscle spindles. We don't want to get any sort of stretch reflex happening to increase that tone again. So really important that we simply slowly return back to a neutral position, still holding on to that tender point. And the final step with any of our treatments, repalpate. How does that feel to the client? Does it feel different? What was a 10 hopefully is still that 2 or 3 or even gone. And you, the therapist, will be able to palpate the difference in tone. So let's summarize that. Identify the target tissue. Palpate the tender point. Now let's tell our clients that's our 10. Position into a shorter position of ease and fine tune it. You might need to make 2, 3, 4 movements to get down to that 3 or 2. Hold for 90 seconds and slowly return to neutral. It's as simple as that. So some general guidelines for finding ease. If it's on the front of the body, generally flexing the body will shorten that tissue. Not always the case, but in a lot of cases, start with flexion. If that doesn't create ease, extend. Simple as that. On the posterior of the body, generally requires extension, but not always. Distal, the further away that tissue is from the midline of the body, the more side bend or rotation is generally needed to achieve ease in the tissue. You might find that when you're really in the middle, when you're really medial towards that midline, that actually just a flexion or extension is enough to get to that 3 or 2 out of 10. If there's more than one tender point, Choose the most proximal and medial. So let's go right towards that midline. If the tender points appear as a line of points, treat the most central, treat the middle one. Don't treat more than 5 tender points in one area in one session, as this may lead to adaptive overload and just prove too much for your clients. As always, less is more. Let's chip away and let's not try to change the whole world in just one session. Considerations. Jones, for example, created a very clear guideline and books of where the tender points would be in each of the muscles and how to then bring those tissues into a position of ease. Make what is already shorter. And I think that's really useful. It's like all of these things. They're a great guidance, a great starting point. But we know so much more about the body now, especially with the fascial restrictions. We don't know what scarring's within that tissue. Every body is different. So let's caveat all of that good guidelines with the fact that every client's strain and pain is different. So communication is at the center of this technique. It's vital that we talk to our clients. They are the only person who can tell us if we've reached a position of ease. You may feel like it's eased, but your client may not feel that. So we need to communicate. And as always, integrate this with your assessment, your approach, and your palpation skills. As strain, counter strain, positional release alone is not necessarily the answer for your client, but is a fantastic tool as part of your integrated longer-term plan. In terms of contraindications and modifications, all the general massage ones apply. There's no change there. Special care should be taken if you're working over skin conditions. So even though we can do this technique through clothes, you're going to be holding a tender spot for a period of time with some pressure. So if their skin is delicate, if they have a rash, that may be uncomfortable for your client. So communicate and work within your client's pain restrictions. Also, protective spasm should not be released. So for example, if someone has a fracture and they're protecting that and they're in the early stages of healing, we don't want to remove protective spasm. Any increase in pain during the treatment, as with any manual therapy, shows an undesirable direction or reaction to what you're doing. It may simply be that the movement or position that you have found in has increased the discomfort rather than decreased it. So come out of that position, move in the opposite direction and look for that position of ease. If no position creates ease and all positions are increasing pain, then that would say to me this client is in an acute phase and potentially needs to be referred to a physio or an osteopath or even their GP. So as always, if what you're doing is making things worse, refer onwards. Stay in your lane. So references. This book is the Bible when it comes to positional release techniques. Leon Chato's an expert and really describes in the most simplest way how to do various positional release techniques. This book covers not only strain, counter strain, functional technique, McKenzie, even some taping techniques. So a really useful resource if you find you like this technique and it fits well within your practice. This is a really great resource. And here's just a handful of research papers. There are so many out there. Even within that book on positional release, there are tens, if not hundreds of studies on positional release. So there are lots of resources out there if you're interested in reading a little bit more about how positional release can be integrated to help in various musculoskeletal conditions.